Enhanced CPR Safety, mock Code Blue drills. There have been some changes to the way we respond to Code Blues due to COVID. The following Code Blue drill will show you what those changes are and why they have changed. For our scenario, the patient is a rollout for COVID. He is found unresponsive by his nurse. Let's see what happens.
Billy, are you okay? I need some help in here. Code Blue.
Notice that the nurse is already wearing his PPE before he entered the room. He calls out a Code Blue and performs compression-only CPR. CPR is a high-hazard procedure and can aerosolize the patient's droplets, making the disease airborne. Because this is a high-hazard activity, the appropriate PPE would be to wear a PAPR. The nurse in this situation is going to provide CPR only long enough until he is relieved by a team wearing the appropriate PPE, such as a PAPR. Bagging the patient is also high hazard. Intubation should be immediate so that bagging can be avoided if at all possible. We will discuss the bagging of a COVID patient later in this video. Before staff start arriving to this COVID Code Blue, let's talk about who should be going into the room and who should stay out of the room. There should only be 5 people going into the room who we will call essential staff members. They are the provider, respiratory therapist, an RN whose role is to defibrillate and push meds, and 2 people to perform compressions. These roles should be filled by specific people, not just the first 5 who show up. We need certain staff members to fill those roles. The provider and respiratory therapist roles are self-explanatory. The RN should be filled by a rapid response nurse. Our rapid response nurses have specialized training, such as placing intraosseous catheters and other specialized training that is utilized during codes. The compressor should be filled by a second respiratory therapist and a second rapid response nurse when possible. If a second rapid response nurse and respiratory therapist are not available, those roles should be filled by nurses, as they are able to push meds or run the ZOL when not doing compressions. Why are we limiting staff inside the room? Most organizations, such as AHA and SCCM, recommend limiting staff in the room, especially for COVID and persons under investigation. CPR is a high aerosolizing procedure. By decreasing the number of staff in the room, we limit potential exposure. In our current climate, we want to make sure that we can provide staff with the appropriate PPE during a code. Historically, we've had too many people in the room during a code, which adds to the noise level. Clearly defined roles will allow the providers to direct tasks to individual staff versus shouting out a task and hoping someone will complete the task. Now let's see how these 5 essential employees arrive to the code. When a Code Blue is called overhead, the charge nurse will respond with the crash cart and stay outside of the room. Additionally, there is a special PPE cart. We have 2 in-house. One is in OC Adams building on the ortho unit, and the other is in the WCC building on the medical ICU. The charge nurses from those units are both responsible for bringing that cart with them. Whichever charge nurse with the PPE cart shows up first will be the cart and charge nurse that stays to help. You will also see that another nurse on the unit, who is not one of the essential staff, grabs a WOW computer and takes on the role as recorder outside of the room, which we will discuss that role later. Notice the charge nurses do not rush into the room. They are not the essential staff. Their role is to get the essential staff ready and safe to enter the room. They also will man their carts and get equipment ready to go in. Notice the charge nurse who arrived with the cart begins handing out the gowns from the PPE cart. Let's pause right here and discuss what is on this cart and why it is so important. The PPE code cart is equipped with special PPE. Let's start from the top left. This is the video laryngoscope, which is velcroed to the side and easy to remove. This is essential as it will assist the provider with a quick and easy intubation. We want intubation to go as smoothly and quickly as possible to reduce aerosolization. The cart is also equipped with 5 PAPRs for the 5 essential staff members. The PAPR batteries are plugged in on top and also include the essential staff role badges. The baby monitor located on top has an inside and outside monitor which are labeled. The RRT bag has items that the RRT uses during codes. The drawer contains N95s, goggles, and gowns. The middle shelf has the PAPR hoods and PAPR motors. The red bin contains respiratory therapy items such as the viral filter and other various items that are specific for COVID code blues. You will see those items in action during the drill. As the essential staff are putting on their PPE and PAPRs, the house supervisor has arrived. The house supervisor will man the door and ensure that only the 5 essential staff are going into the room. She is the gatekeeper. She will also assign roles for the rest of the staff outside of the room. Notice how the charge nurse assists staff with putting on PPE and setting up their PAPRs. The other nurse is assisting in handing out the roll badges. She also puts the outside baby monitor on the wow so the recorder can hear what is going on inside of the code room. We can also see her gather other essential items such as the inside baby monitor, the viral filter, the backboard, and unstrapping the Zoll from the crash cart. The crash cart stays outside of the room, which is why the essential staff must bring these items into the room with them. The gatekeeper house supervisor verifies that only essential staff enter the room. The nurse hands the backboard and inside baby monitor to the first person going into the room. The second person is given the Zoll. The respiratory therapist was handed the viral filter. The second respiratory therapist and provider follow the team in. The first person into the room arrives with the backboard and the baby monitor. It is important to note that the inside baby monitor must be plugged into an outlet in order for it to work.
Can you hear me?
She tests the monitor and hangs it on an IV pole near the patient so that the recorder can hear what is going on inside of the room. The second person arrives with the Zoll. She turns it on and places the pads on the patient. Now the respiratory therapist has arrived, and she assists with getting the backboard under the patient. She also brought with her the viral filter and the laryngoscope. Notice that once these essential tasks are completed, compressor number 1 taps out the primary nurse so that he may now leave the room. The primary RN leaves the patient to the care of the essential team. He will now be in charge of closed-loop communication by using the baby monitor to communicate with the team inside. He will also stand next to the recorder and keep her informed, so that she may chart everything in real time. He will now give the team report.
This is Billy Johnson, a 62-year-old male admitted for chest pain, fever, cough, and a non-STEMI. He has a history of smoking, diabetes, and PCI with 2 stents placed 2 years ago. In the ED, he started having intermittent chest pain over the past week, but the chest pain resolved. The EKG showed ST inversion in V1 through V4. Initial troponins 3 hours prior was 1.15. He's being ruled out for COVID.
Let's pause here and discuss bagging a patient with COVID. In this particular scenario, the patient needed to be bagged with a BVM. Bagging is a high-risk procedure as it aerosolizes droplets. If we are going to bag a COVID patient, it is mandatory that 2 people perform bagging together using the following method. One of the ways we can reduce vapor exposure to staff is by using the viral filter. The viral filter is placed in between the bag and mask portions of the BVM. The second way we can reduce vapor exposure is by maintaining a good seal around the mask. This is done by one person using a 2-hand method to seal the mask to the patient's face, and maintaining a patent airway using the jaw thrust method as shown. This requires a second person to do the bagging. In the video, the provider is maintaining a 2-hand seal while the respiratory therapist bags the patient. Let's see how closed-loop communication is achieved using the baby monitors with the team inside and with the outside team.
Epinephrine 1 milligram.
Epinephrine 1 milligram is ready at the door.
The pharmacist heard the order and prepared the medication.
Epinephrine 1 milligram. I have epinephrine 1 milligram.
Epinephrine 1 milligram given.
Epinephrine 1 milligram was given.
The team is now preparing to intubate the patient. The physician asks for the ET tube over the monitor, and there is a third respiratory therapist outside preparing his intubation supplies. The primary RN manning the radio notifies the inside team that the intubation supplies are ready at the door. The second compressor retrieves those supplies at the door and brings them into the room and hands them to the provider and RT. It is very important that we do not perform CPR during intubation. CPR is a high-hazard aerosolizing procedure. While the patient's mouth is open and the provider is close to the patient's face, we do not want to spray the patient's droplets and vapors into the provider's face and into the room. This is why a laryngoscope is used to aid in a quick and successful intubation. Notice that compressor number 2 does not resume CPR until the viral filter is in place on the ET tube. We also will not be using the color-changing CO2 detector. Instead, we will go straight to the CO2 detector attached to the Zoll. This ensures that we only have to break the circuit once as opposed to twice if we were to use the color-changing CO2 detector. When we shock a patient, we must disconnect the oxygen from the patient before delivering the shock. Notice how the RT leaves the viral filter in place on the ET tube.
All clear? Oxygen off?
All clear. Oxygen is off.
All clear. Deliver shock.
Shock delivered. Resume CPR.
Now that you have seen the drill with explanation, let's see this work in real time.
Billy? Billy, are you okay? I need some help in here. Code blue.
Can you hear me?
Yes, we can hear you.
Check pad. Check pad.
Do we have any of your bags?
I do? Yeah. I got the backboard here, guys.
This is Billy Johnson, a 62-year-old male admitted for chest pain, fever, cough, and a non-STEMI. He has a history of smoking, diabetes, and PCI with 2 stents placed 2 years ago. In the ED, he started having intermittent chest pain over the past week, but the chest pain resolved. The EKG showed ST inversion in V1 through V4. Initial troponins 3 hour prior was 1.15. He's being ruled out for COVID.
Epinephrine 1 milligram.
Epinephrine 1 milligram is ready at the door.
Epinephrine 1 milligram.
I have epinephrine 1 milligram.
Epinephrine 1 milligram given.
Epinephrine 1 milligram was given.
Please prepare an 8.0 ET tube with stylet.
ET tube with stylet is ready at the door.
8.0 ET tube with stylet.
Here is the 8.0 ET tube with stylet.
Hold compressions for a pulse check.
Pulse check, no pulse.
Rhythm is PEA. Hold compressions for intubation.
Resume compressions. Hold compressions for a pulse check.
Pulse check, no pulse.
Rhythm is ventricular fibrillation. Continue CPR.
Charging to 200 joules. All clear? Oxygen off?
All clear. Oxygen is off.
All clear. Deliver shock.
Shock delivered. Resume CPR.
Please keep in mind that there are different types of PPE used based on the isolation precautions. In this particular scenario, the patient was a rule-out for COVID. Therefore, the nurse was wearing an N95 and eye protection when entering the room. It is recommended that PAPRs be worn as a precaution when performing intubation with or without compressions for droplet or airborne precautions. Therefore, the essential staff who will be performing these tasks will be wearing PAPRs. For any further questions, please refer to Kim Watson, MSN RN, Director of Medical ICU at SMCS. This video is for reference and education purposes only. The authors, actors, and producers assume no liability for use of techniques described. The authors do not give consent to use the video for any other intended purpose without permission from the author prior to use.